Okay, continuing with the heart. We're going to look at the cardiac cycle, what happens during a heartbeat. So it's all the events that happen from the start of one heartbeat to the start of the next. Systole, as I've already mentioned, is when the heart muscle is contracting, and diastole is when it's relaxing. Be very careful. You've probably already learned how to take people's blood pressure and such. Maybe you haven't, but you will shortly. The systolic blood pressure, which is the higher number, is the blood pressure at the time of systole. The diastolic blood pressure, which is the lower number, is the blood pressure at the time of heart diastole. So if on a test you are asked to define systole, the answer is the contraction of the myocardium, not the higher number in blood pressure. The blood pressure number is the blood pressure. Systolic means blood pressure at the time of systole, which is the contraction of the heart. As contraction happens in the heart, pressure goes up. Anytime you squeeze anything, the pressure goes up. If you squeeze a ketchup bottle, it pushes the ketchup out because liquids move from areas of high pressure to areas of low pressure. So we use this to move the blood. And the valves ensure that the flow is unidirectional, prevents backflow. So there we go. So when the ventricles contract, it raises the pressure within the ventricles. It closes the atrioventricular valves, the mitral valve and the tricuspid, opens the semilunar valve, and blood is ejected out into the arteries. That's systole. In diastole, the pressure goes lower because the space is expanding. The pressure in the ventricle gets below the pressure in the aorta or the pulmonary, and the semilunar valves will close, making the sound. And then the atrioventricular valves open when the pressure is not pushing them closed, and blood will flow from the atrium into the ventricle. So we're going to start in diastole. All four chambers are at rest. Blood is returning to both atria from the vena cava and the pulmonary veins. Blood is flowing right through the atrium, through the open AV valves, and into the ventricle. And it's because there's the presence of blood in the atria coming from the veins is a higher pressure than in the ventricles, which are at low pressure. And so we get this passive filling. At this time, the semilunar valves are closed, so there's no blood coming from the aorta or the pulmonary trunk, because the pressure in the ventricles is lower than the pressure in the arteries, and then those valves are closed. So this is passive filling. This is early to mid diastole, or middle to late diastole, actually. Then what happens is the atrium contract. The atrial get a atrial systole, and because the SA node has fired, and what happens is you get a little squeeze of blood from the atrium into the ventricle. The ventricles now have as much blood in them as they're going to. And this is the end of diastole. So we call that amount of blood that's in the ventricles at the end of diastole the end diastolic volume. It's kind of the most blood that there can be in this beat. The atria then relax, and the ventricles start to undergo systole. As the ventricles undergo systole, they put pressure on the volume that's in them. And as the pressure rises, it slams the mitral valve and the tricuspid valve closed. I'm giving you the first heart sound. And then, but the ventricular pressure is still less at this point than in the aorta, for instance. So the semilunar valves are closed. So that means both doors are closed in the ventricle. So the volume doesn't change. So we call this isovolumetric contraction. It doesn't last very long, but it's a time when pressures are rising and AV valves and semilunar valves are closed. So the volume doesn't change. Isovolumetric. When the pressure has now increased because the systole is continuing, the contraction is continuing, the pressure increases and it throws open the semilunar valves, the blood that's in the ventricles gets squirted out into the arteries. We call the amount of blood that leaves in this ejection the stroke volume. It's the amount of blood ejected. Now, not all the blood leaves the ventricle. It depends on how hard you're squeezing it and how much pressure is in the aorta that you're squeezing into. But a good amount ends up going. It's usually someplace around 60 to 70 milliliters. There's always some blood left in the ventricles. And then systole ends. So we call this the end systolic volume. This is the amount of blood that's left over after blood has left. So really, the stroke volume is the end diastolic volume minus the end systolic volume. So if we push, like this equation is just worded awkwardly, but if at the end of filling we have 130 mils into put into the ventricle, and 60 mils are left in the ventricle at the end of systole, that means 70 mils got ejected, so the stroke volume is 70. Or you can look at it that if there was 130 mils to begin with at the beginning of systole, the end of diastole, and 70 mils are ejected, then there's 60 mils left. We're really more interested in the stroke volume because that's the blood that ends up going to your body. So then what happens is diastole starts. As diastole starts, the pressure drops within the ventricle. As soon as the pressure in the ventricle is lower than that of the aorta or the pulmonary trunk, then the semilunar valves close. When the semilunar valves close, we get the second sound, but the pressure is still higher than the atrium, so now it's a closed chamber again with both sets of doors closed, so it's isovolumetric. But the pressure is dropping, so we call this isovolumetric relaxation. And then the valves open, everything is relaxed, and the blood flows, and we start again for the next heartbeat. So this is just a chart of that. Atrial contraction, or ventricular filling first, and then the atrium contracts, and it pushes the last 20% of blood in there. Isovolume volumetric contraction, so ventricular systole, closes the AV valve, hasn't opened the semilunar valve yet. Then the semilunar valve opens, you get ejection into the arteries. Then you get isovolumetric relaxation. So this starts to relax, pressure drops. This closes first, second heart sound, but it's still not ready for this to open. It finally drops to low enough that the mitral valve opens and blood flows in passively, and you start again. Equal amounts of blood have to be pumped from the left and the right side of the heart because you don't want one catching up on the other. In pathology, you're going to talk about this, right-sided heart failure and left-sided heart failure and the edema caused by it and the health problems caused by it. But fundamentally, in a healthy person, the left side pumps the same amount as the right side per minute. The cardiac output is equal in the systemic circuit and the pulmonary circuit. So you can answer these questions. Okay, we're going to continue with the idea of cardiac output. So what we care about is really how much blood gets out to circulation per minute. We don't really care about how much blood gets out there per heartbeat, because we can change the heartbeat and we can change the amount of blood that leaves per heartbeat. What the body needs is the perfusion. It needs to have a certain amount of oxygen and nutrients brought to the tissues that are metabolically active in the right amount at the right time. So we call this whole thing cardiac output, and it's the amount of blood pumped by a ventricle in a minute, liters per minute. This is going to vary with demands, but we work it out by saying that the stroke volume, the amount per beat, times the heart rate, beats per minute, gives us amount per minute. So 75 beats a minute, 70 milliliters per beat, gives us 5.25 liters per minute. Now that's a normal resting cardiac output. It's interesting because we have about 5 liters of blood, so that means that every drop of your blood goes through each ventricle every minute. It shows you the speed that this stuff moves. And that's at rest. When we exercise, it can be 4 or 5 times that. We have to meet the tissue needs. So if stroke volume goes down, then heart rate has to go up. So that's why little kids, because they have smaller hearts, have higher heart rates. And that's why small animals have high heart rates. Larger hearts, stronger hearts, you can have a slower heart rate because your stroke volume is high. To have the resting cardiac output, you don't need as much heart rate. The whole point of getting in shape is to increase your stroke volume so you can decrease your heart rate. And that means then, if you increase your heart rate at the same stroke volume, you will increase cardiac output significantly, very quickly. This is called cardiac reserve. So if you take the cardiac output at rest from the total output at exercise, you can have a huge amount of change. It's saying that in a really fit endurance athlete, you can have 7 times the cardiac output. And when you think about that, you have 5 liters of blood in your body. Resting is 5 liters per minute. 7 times 5 is 35 liters a minute. So that means that your blood is going through your entire circulatory system 7 times a minute. It's just seconds from your heart to your capillaries and back. Crazy. This is called the cardiac reserve. The better in shape you are, and this is the whole reason you take classes, you take spin classes and stuff, and you have a cardio workout day, is to increase this cardiac reserve. And you know you're doing it because your resting heart rate goes down because your stroke volume goes up. So if we're going to manipulate cardiac output, we either manipulate heart rate or we manipulate stroke volume. So we'll talk about manipulating heart rate first. So anything that causes increased heart rate is called positive chronotropic agents. The most important one is the sympathetic nervous system, adrenaline, epinephrine. I don't really care that you know how it works with the G proteins and the cyclic AMP, etc. But one of the interesting things is that the receptor to this adrenaline are the beta receptors. So if somebody is having heart problems and we need to decrease their blood pressure and decrease their cardiac output, we give them drugs called beta blockers, which blocks this. Thyroid hormone increases caffeine, nicotine, coke, etc. All kinds of things can happen. Negative, that decreased heart rate, is parasympathetic. It's acetylcholine, beta blocker drugs, that kind of thing. So we can speed up the heart, we can slow it down to change cardiac output, or we can change the stroke volume. So stroke volume is influenced by preload, contractility, and afterload. Preload is really how much filling you get. You can increase stroke volume by increasing the end diastolic volume. And the best way to do that is increase venous return. More blood returns to the heart. So the end diastolic volume will go up. So that can be because of time. So a slower heart rate increases venous return because there's more time for blood to go back. Breathing deeply will actually suck blood because the thorax, when you take a deep breath, the pressure in the thorax goes down, which will pull blood towards the heart, which is in the thorax. Skeletal muscles contracting will also squeeze veins and push the blood towards the heart via their valves. So those three things increase venous return, which in turn increases end diastolic volume, which then increases stroke volume. Now, one of the interesting things is that as the heart fills, it stretches, and the overlap between actin and myosin, the thin and thick filaments, becomes optimal, and contractility of the heart is improved with this, and so that will also increase stroke volume. Frank Starling's law says that as the preload happens, there's more blood to pump, and you pump it better. So it has a huge determinant on stroke volume. So this is the muscle pressure increases, time increases venous return. venous return will decrease if you lose blood. So if you're hemorrhaging. If you're hemorrhaging, your heart rate has to speed up to maintain a stroke volume. If your heart is racing, then stroke volume goes down because there's not enough time for filling. So it balances out. So contractility refers to the force of contraction from everything except preload. So this would be thyroid hormones, epinephrine, all kinds of things like that. Negatively would be different drugs and, ionic balances, etc. Afterload is the resistance in the blood vessels. So how hard is it to push the blood out of the heart? You're going to push less out if it's hard. If we're going to use the analogy of a bicycle pump. You've all pumped up bicycle tires. You pull the bar up, putting lots of air in the pump, that's preload. You push it down hard, that's contractility. And when you're doing that, you move a lot of air into the tire. But as the tire fills with air and the pressure increases, it's harder and harder to push the air into the tire. And you have to increase contractility to move more air into the tire. That's the afterload. So what happens with afterload is that it increases end systolic volume and therefore decreases stroke volume. So somebody that's hypertensive, their heart has to work harder, it needs more contractility because there's more afterload. You lower your blood pressure, afterload goes down, stroke volume goes up, heart doesn't have to work as hard. So this is just a chart of all of that. So I'll let you just read it through. And afterload. So to summarize it, heart rate, it depends on the different agents. Stroke volume depends on how strong the heart is, the agents that influence cross-bridge formation, afterload, and preload. And this chart brings it all together.